We are live.
Speech, language, hearing are very important for communication. They connect us to the people around us. Good evening. I'm Meenakshi Vadhera, an audiologist, speech language pathologist. And on behalf of Indian Speech and Hearing Association, I welcome you all to another evening of Speech and Hearing Awareness Annuals 2020. As you all know, that in collaboration with all our branches, chapters, training institutes, and professionals, these events are being conducted pan India. And free teleconsultations is also being provided at most parts of India. But before we start today's evening, I would like to request Dr. Arun Banik, our past president of Indian Speech and Hearing Association, to say a few words. Sir.
Thank you, Dr. Minashi. Good evening to all the members present here. First of all, on behalf of the President and Executive Council members of Indian Speech Language and Hearing Association, I welcome to everyone for today's evening a very important workshop webinar that we are organizing. As you all know that Indian Speech Language and Hearing Associations is taken an extensive efforts to create an awareness in Speech and Hearing Weeks Annuals 2020 started from 1st December to 15th December throughout India as well as international. We have been seeing that in the last few days, all our chapters, branches, our fellow professionals, all ours, the private practitioners, the educational institutions, and all the professionals is become proactive to organizing to participate in such an events, which is very promising. This kind of activity is very essential to strengthen our profession as well as to promote our profession and association as well. I'm happy that such kind of activities should continue for all the times, every year, all branches, all chapters, all professional, so that we can strengthen ourselves. For that, we are also very thankful all our the executive council members and the professionals who are involved for such an activity and coming out successfully for all the events being held and going to organize until 15th of December. I am sure that this will carry a long message, a long weightage to every one of us to focusing to develop our profession as well throughout India as well internationally. So that is why uh, we require to join hands together and work together for the development promotions of all the disabilities area where our services are very essential. I further also welcome all the resource person today and the panelists for participating very important topics, the hearing well-beings and the role of audiologist for in the assessment of adults. So these are the things that is why required, that is why we need to see that our profession, it should come up from such a as a super specialty area, so that everyone in each and every discipline, interdiscipline, in this area we can able to participate and work for the betterment, for better future, all of us. I welcome all of you, and I'm sure that today's this important webinar will give a lot of message and lot of knowledge sharing for further growth and development of our profession. I welcome all of you. Thank you very much for giving me an opportunity to a few viewers in this occasion. Thank you. Welcome once again.
Thank you, sir, for very inspiring words. As Helen Keller said, the problem of deafness are deeper and more complex, for it means the loss of most vital stimulus, the sound of the voice that brings language, sets our thoughts astray, and keep us in the intellectual company of the man. So, our topic today focuses on the hearing loss in adults. But before we begin with that, yesterday we covered yet another exciting topic on interprofessional collaborative practices with patient as the center of the practice. But if you missed it, don't worry, you can still watch it on our YouTube channel, Isha Annuals. These are some of the events that we would be covering in the coming days. So please join us for these sessions as well. So, as I already said that we would be covering, you know, about hearing loss, adult hearing, what we can do about it, with a set of very eminent panelists who are practicing, who you know takes care of your hearing healthcare every day. So this panel is being moderated by Mr. Achaya. So I would like to thank our event sponsors. So Mr. Achaya is a master in audiology from Aish. He has his own clinic by the name of Resonance Speech and Hearing Clinic. He was involved in NPPCD program for distribution of hearing aids and EDIP schemes for CI. He works closely with Swami Vivekanand Youth Movement Organization for newborn hearing screening. He's not just doing a professional work, he also is involved with lot of social work. He's involved with NGO called Kodagu for Tomorrow, which is involved in rebuilding lives of people who are affected during the floods in Kodagu in 2008. Over to you, Mr. Chaya.
One and all, on I welcome you all to the Indian Speech and Hearing Association Speech and Hearing Awareness Annuals 2020. Today's topic of the panel discussion is Well Hearing is Well-Being, Role of Audiologists in Overcoming Hearing Loss in Adults. As you all know, hearing loss, a person who is diagnosed with hearing loss, of course, suffers. And along with that, the family, like how we had discussed, or there was a discussion about the economics of disability day before yesterday in one of the panel discussions, how it was mentioned that a person who has hearing loss or any handicap not just affects the hearing loss, not just affects the person, but also the family, the village, the state, and even the country. The productivity goes down. This is so an issue like hearing loss has such a devastating effect. So the panel discussion here, we will be discussing about how to overcome this and how the people or adults or elderly population who have hearing loss can overcome this and lead a normal life. So without further ado, first of all, I'd like to welcome all the panelists. The panelists, first I would like to welcome Dr. Chandan Saha. Yeah. Dr. Chandan Saha completed his MSc in 1999. He started his practice in 2000. Sir has completed his AUD and was awarded doctorate in October 2020. And he has been in private practice since 2000 and has also worked as an academician for a year in MERF, Chennai. Presently, he is the director at Decibel Audiology and Speech Clinic Private Limited, Kolkata. I welcome you, sir. The next panelist is Dr. Arivudai Nambi. Nambi sir completed his BSc in 2005 and MSc in Audiology from Aish in 2007. Sir has completed his PhD and was awarded doctorate in 2017 from Manipal Academy of Higher Education. Sir has been working as Associate Professor in KMC Mangalore since 2008. He has several publications in index journals and has a few funded research projects to his credit. Nambi sir, welcome to the panel discussion.
Thank you.
The next panelist is Mohammed Ismail. He completed his BSc in 2007 and MSc in Audiology from Aish in 2009. He is presently working as audiology trainer at Amplifone India and has a rich experience of 10 years in hospital and standalone clinic setup. He has also received Charles Holland Award in 2010 as a clinician for following the best clinical practices. Ismail sir, welcome to the panel discussion. The next panelist is Mr. Avinash Grupp. He has been associated with Sonova Hearing India Private Limited since 10 years and has been working as the senior audiologist. Prior to that, he was the clinical specialist in Cochlear India for India and South Asia for 5 years. Also, an interesting thing is that he's an accomplished pianist and he has many laurels to his name. Avinash, welcome to the panel. The next panelist is Dr. Aninda Manik. He completed his MSc in Audiology and SLP from AYJ NISHD, Mumbai. He completed his PhD and was awarded doctorate in CAPD. Has an experience of 10 years and is presently working as the clinical research specialist cochlear implants in advanced bionics. He has 4 international publications to his credit and is running 4 research projects in cochlear implants in India. Welcome, Dr. Aninda.
Thank you.
And the other panelist is Ms. Afreen Sandhu. She has been associated with Sonova Hearing India Private Limited since 8 years. She has handled various roles in Sonova and Unitron, starting from audiologist trainer for India and Southeast Asia, and has been working as senior audiologist for Sonova and handling Phonak and Unitron since the last 5 years. She also has 2 years of clinical experience. I welcome you, Afreen. Now we'll straight away dive into the panel discussion. As I was talking about earlier, the effects of hearing loss, the devastating effects of hearing loss. So I pose the first question to Afreen, and I request her to kindly explain in brief what are the devastating effects of hearing loss. I mean, other than the obvious ones, even the invisible effects that happen due to hearing loss. Over to you, Afreen.
Thank you, Achaya, for the introduction. I will be talking about hearing loss and well-being. I shall share my screen. Achaya, you need to stop sharing your screen so that, yes. So kindly confirm if my screen is visible.
Yes, ma'am, you can go ahead.
Yes, thank you. So, as audiologists, we have a long standing understanding of the impact of hearing loss on interpersonal communication and relationships. However, recent research have actually focused on less known obvious impacts of hearing loss that can interfere with multiple domains of a person's quality of life. So hearing loss actually is not just about mere inability to hear well, but it is about the overall well-being and healthy living. So if I had to talk about well-being, Well-being is actually understood differently. It's more personal and multidimensional. For some, it could be about happiness, independence, or staying active. While for the others, it would be more about social participation, fulfilling relationship with families and friends, achievement in workplaces. Definition of well-being is actually fluid. It can change throughout life. Whereas WHO constitution has actually defined health not merely the absence of a disease, but a stage of complete physical, mental, and a social well-being. So when we have to look at the hearing health in particular, hearing loss and communication challenges due to hearing loss can actually impact all the three dimensions specified by WHO. This calls for action for a number of reasons. The impact of hearing loss on well-being is very often underestimated. Even though hearing loss is highly prevalent, hearing loss is undertreated. So, hearing loss quite often is actually considered as mere sensory problem, but there are a lot of other associated problems. It could be coexisting underlying diseases such as arthritis, diabetes, cardiovascular diseases, or also a high risk of fall, increased use of healthcare services, cognitive problem. Hearing loss is also associated with social and emotional burden, which reflects in the form of increased feeling of loneliness, distress, depression, and an overall lower quality of life. So though we know that hearing loss is highly prevalent, it's the fifth leading cause of disability across ages, but yet hearing loss is undertreated. Not many people actually adopt hearing aids. So evidence shows that if you take step towards the hearing well-being, that is preventing, detecting, and treating hearing loss, we can actually lead to noticeable improvement in well-being. So this model of well-being, it can be easily implemented in clinical audiological practices. Your research shows that hearing rehabilitation is actually linked to improvement in three domains. That's your social, emotional, physical, and the cognitive domain. So I strongly believe that if hearing well is actually taken into consideration, it can actually foster easier engagement, stronger connections, and a more positive outlook. Supports cognitive fitness and enables people to live a more healthy lifestyle. So if I have to talk about the social ties, so if I talk about like out of the three domains, if I have to focus on talk about the social emotional domain, here we would agree that supportive social ties is linked to better health outcomes, longer life expectancies, better mental health, and even better cognitive and emotional health. Whereas hearing loss actually is, if I talk about the social emotional domain, it's quite a concern related to hearing loss, which can actually impact your social emotional well-being. People with hearing loss are reported to actually have smaller social networks, more feeling of loneliness, withdrawals, and social isolation. People would actually not prefer, people with hearing loss actually try not to be a part of social gatherings or an outing. They do not enjoy social situations. They're less interactive. So these are this could actually lead to a social emotional well-being. Whereas there has if we actually treat hearing loss, this could actually turn the situation around and allow clients to actually live a more longer and a healthier life. And research has actually shown that hearing aid adopters actually report benefit with hearing aid use, better ability to engage in group activities, positive impact on relations. So these are the few aspects of social emotional. Whereas if I talk about the cognitive aspects, so moving on to the cognitive domain, persons with hearing loss are more at risk of developing clinically significant cognitive problems at an older age. The brain, as we all know, plays a crucial role in listening and speech understanding. It's important to keep it stimulated. And at this instance, that's when the hearing aids come into play. Evidence shows that hearing aids may delay the onset of cognitive decline. There are also a lot more short-term effects of hearing aids on cognition, wherein better performances on secondary tasks performed at the same time as a primary task. For example, if I would give that, seeing a visual, you actually press a button, wherein at the same time you are performing a listening task. So your visuals and pressing a button would be your secondary task, whereas listening to audition would be your primary task. And then also, if your ability to hear subtle sounds can make listening easier, less effortful. uh, the reduced listening efforts could actually free up your cognitive resources for purposes other than listening, and reduce feeling of fatigue. For example, being aware of the being aware of the footsteps of someone approaching, or a splash of water. So these things could actually hearing loss can make this lot more challenging. So therefore, the ability to hear even these subtle sounds can actually ease off the well-being. Coming to the physical well-being part, wherein it's less likely known that the physical dimension of well-being also can have a link to hearing loss, but it is still a very important one, where our sense of hearing contributes to a sense of environmental awareness. It helps in processing and interpreting spatial information of sound. Hearing allows us to actually listen and monitor changes in the acoustic environment. Whereas if you have a hearing loss can make this more challenging, reducing access to subtle sounds, problem in localizing a source of sound. So this can actually affect. Whereas if listeners with hearing loss, like, they spend most of the time actually putting in efforts to maintain awareness of their environments, of what's happening around, extra effort is spent on auditory tasks. So, and therefore your extra efforts are spent on auditory tasks, and it may actually compromise on your environmental awareness, may compromise the ability of the cognitive resources to be used for other functions, because you'll all the time be more alert. It will actually lead to more of cognitive fatigue. It may lead to more effortful listening in that case. So again, talking about the postural control, it's been hypothesized that the older age people are more vulnerable to have an impact on postural control. So when I talk about postural control, it is more of a complex motor skill that actually allows us to achieve, maintain, and restore balance, control our movements, and actually prevent us from falling down. So to achieve this postural control, we actually rely on a multi-sensory feedback system, which is like the auditory, the vestibular, the visual, and the proprioceptive information. When inputs to this multi-sensory feedback system are reduced, maybe by visual or by auditory impairment, postural controls can actually be challenged. So older adults, therefore, are actually with the hearing loss are significantly more at a risk of falling than their normal peers. And as we know that a fall often may result into more detrimental outcomes, it may lead to loss of confidence, serious injuries, and therefore it is of high interest that we actually address risk factors of falling, such as hearing loss. Interestingly, research also suggests positive effects of hearing aid use on postural stability and balance in individuals with actually hearing loss. So if I had to summarize the entire concept of this well hearing, what does this mean for clinical practices? So it's basically taking step towards hearing well, which is linked to more noticeable improvements in your physical, cognitive, and social, emotional dimensions of well-being. Hearing, we strongly believe that hearing well enables to foster easier engagement, stronger connections, and a more positive outlook. It supports more cognitive fitness and enables people to live a more active and a healthy life. So it is actually time that we start talking about it, because it's not just about helping people to hear better, but also to live better. So definitely in our day-to-day practices, I feel that we should be talking more about the well-being and not just the hearing aspect to it. So yes, thank you.
Thank you, Afrin. I think those were some good points that you put across about it's not just about good hearing, but about well-being, to take it holistically, and not just about just the hearing part of it. Thank you. To inform everybody, we'll be taking questions at the last. Those who want to ask any questions, you can just type in. There's a Q&A section given at the bottom. you can type in your questions and we will be taking questions in there. Now moving on to the next one. A lot of times during my practice, I've seen that people usually do not acknowledge that they have hearing loss. They either try to avoid, or they say, no, I can hear it pretty well. I'm fine. There's no problem. They speak softly. The family members, the friends speak softly. No, my hearing is fine. We as audiologists would have heard all these excuses. So I pose this question to Nambi sir. Why is that people do not acknowledge their hearing loss? Is it a perceptual issue, or they do not want to accept it? Accept that they do not have that they have hearing loss. Nambi sir, over to you.
Thank you, Achya, and I would like to thank the organizers for giving me this opportunity. Uh, uh, I was told that can you stop sharing the screen? Can you see the slides?
Yes, sir.
So I was told that this panel discussion, more target towards the general audience. So I'll try to keep my answer as much as general possible. Okay. So as Achia pointed out, okay, there are certain clients, some clients who don't acknowledge their hearing loss. Okay. So as an audiologist, all of us would have come across three types of patient. Okay. The one who acknowledges their hearing loss and motivated to wear hearing aids. Okay. Often these clients self-realize that they have a hearing problem, okay, because they would have had communication difficulty in the workplace, unable to communicate with their customers, and it would have been indicated by their family and friends. So they go to the audiologist, and audiologist do the assessment, and that assessment results and their perceptual effects do match. So then they get motivated to do something about their hearing problems, and they learn that hearing aid is the only choice to cope up with their hearing problem. So they motivated to go for hearing aid. Other categories of client is they acknowledge their hearing aids, but they don't want to wear hearing aids, but that's a different issue. But the most difficult clients to manage in our day-to-day clinic is they there are certain clients, they don't acknowledge that they have a hearing loss. Okay. So often these clients report that as Achya pointed out, I can converse easily with my family members at home, so I don't think I have hearing loss. Okay. This happens because these clients often look at the easiness of communication from their point of view, not from their family members or their colleagues point of view. Okay. Often the family members have to either raise their voice, they have to speak louder, or repeat many times to make the client understand. So since the patient do understand the voice and he is able to communicate, he thinks that he doesn't have a problem. Also, there are certain clients who have a slight hearing problem with a milder degree of hearing loss, where they miss out certain sounds, or they have a slow hearing loss where there's certain frequency they hear well, certain frequency they don't hear well. These individuals, they are able to do well in the quiet situation. They may be able to communicate well in the quiet situation. They have problem only in the noisy situations. Hence these individuals do think that yes, I don't have any problem. Okay. So this is basically a perceptual problem where truly they believe that they don't have a hearing loss. Okay. They don't perceive that they have a hearing problem. Okay. However, leaving them as it is will have make the communication difficult, not for him but for his colleagues or family members. So from the audiologist point of view, it is our responsibility to demonstrate yes that you have a hearing loss. So often the well equipped audiology clinics have an calibrated audiometer. So performing a speech audiometry using a ecologically relevant stimulus like a sentences or question answers, and a calibrated calibrated levels of normal conversational level, making the patient respond to the sound, or making him understand that yes, you are not able to follow the conversation, or you are not able to answer to the point. Okay, will make them understand the problem. So with which you'll be able to make the patient understand how the communication was difficult for their family members or colleagues. So this way you can motivate him to do something about the hearing problem. There are some people who don't acknowledge the hearing problem, but these individuals do know that they have a hearing loss, but they don't acknowledge. They often deny that audiological findings, saying that, so when you do an audiometry, say that okay, these are your hearing levels, and you point out when you hear at this level 15 decibels, we say normal hearing. When it goes beyond that, we say you have a hearing loss. But these individuals start questioning your audiometric findings itself, saying that no, I have not concentrated on the sound, I was not paying attention to the sound, I was responding only when I heard the loud sounds. Okay, they start giving some excuses for their audiological test findings. Some even don't accept the perceptual consequence, as once again Achia pointed out that it's not that I am not hearing. Often people mumbling around me, they speak too soft, because of which I am not hearing. So these people have to raise their voice, so they often put the blame on others. Okay, uh, another one is fearing the need to wear hearing aids. Okay, there are a lot of reasons for not wearing the hearing aid. One could be cost of the hearing aid, but there are some government schemes where, or there are some NGOs which do sponsor hearing aid. Even then there are some individuals don't wear hearing aids. Okay, that could be because of a stigma attached to the hearing aid. Okay, maybe wearing a hearing aid, they may feel that wearing a hearing aid, I may be isolated from the community, because most of the people don't wear hearing aid. Because I'm wearing hearing aid, people may isolate me. Or the individual may feel that my hearing problem may be visible to the others. So because of these reasons, they may have to go for a hearing aid, and there are negative emotion attached to the hearing aids. These people may deny that no, I have no hearing loss. Okay. So in this situation, how to cope up such a client is, we have to allow the patient to express the concerns. You have done your objective test through a speech audio, by performing a speech audiometer at a calibrated level. You did demonstrate it to the client. Okay, now the client understood, but why still he does not acknowledge the hearing loss? So you need to understand the patient perspective also. You have to allow the patient to freely express the concern. What is the concern? Whether if you feel that yes, if I wear a hearing aid, I may be socially isolated, or people may understand, or people may get to know that I have hearing loss. But you have to counsel a patient that even if you don't wear the hearing aid, if you don't wear the hearing aid, people will easily get to know, because you may inappropriately respond to the question. When the individual calls you, you may not respond. So not wearing the hearing aid will make your problem more visible than wearing the hearing aid. Maybe you can go for a hearing aid which is invisible, which may be cosmetically appealing, which can make your hearing loss less visible. So you can tailor make your counseling pattern such a way that you allow the patient to express his concern freely and address his concern. And your counseling should also focus on the irrational beliefs and logical flaws in the patient centered manner. The client may argue with you, no, your audiological finding may be wrong, because I'm able to perceive my family members, and I'm able to talk to my colleagues in my cabin. Okay, you have to explain why these individuals are able to hear in certain situation. Maybe his hearing loss is too less, so he is missing out only certain portion of the sound. So due to his due to his cognitive ability, he is able to decode the entire message. Or when he goes to a noisy situation, when the speech related cues, the clues for the speech severely degraded, only then you have a problem. Okay, so you have to explain in a logical manner to understand his problem better. Then these individual get motivated to go for a hearing aid, or to do something about their hearing problem. Yes, such.
Thank you, sir. Uh, you have really put it well, sir, about counseling them and helping them overcome their irrational fears if they have any. Thank you, sir. Now I move on to the next question. Can we go to the next slide, please? Yeah, thank you. Me and my colleagues, my friends, we all have come across situations wherein people with hearing loss delay going in for amplification. They say tomorrow, maybe after 3 months, maybe after 6 months, but not today. So I would pose this question to Ismail sir, that why do people with sensory hearing loss delay in taking up amplification, and what happens due to, what are the detrimental effects due to this delay? Ismail sir, over to you.
Thank you so much, Chair. Firstly, I would like to thank Indian Speech and Hearing Association for considering me to be panelist for today's discussion. If we can move on to the next slide. I think Dr. Nami and Afrin made my life easy by partly answering some of this, the reasons why people delay going for an amplification. In general, we do not have statistics on what exactly would be the time, what exactly would the time taken for any individual from the time that he detects a hearing loss and from the time he owns a hearing aid. There is no, I would say, long scale study that has been available from a country perspective. What we have stats now is predominantly from a Western perspective. Even in the countries with better literacy and the Western countries where they have the government adoption skills as well. Even there, people say that most of the research says that people wait for about anywhere between 5 years to 20 years of time to own their first hearing aid. On an average, one of the study that was done by in the year 2019, it's a longitudinal study that I have taken a reference as. It says that from the time the individual determines or gets his hearing tested and gets detected as having a hearing loss, which is more than mild, he takes about an average of 8.9 years of time to own a hearing aid. It's from a Western scenario. We can only correlate and we can only imagine how it could be in an Indian scenario, which could be a very different scenario compared to that of the Western countries. So it could be significantly longer than what we generally see. And there is a reason why people generally wait for such a longer duration of time to own for a hearing aids. There are multiple factors. It's just not a single reason why people delay to take a hearing aids. Predominantly, what we come across in a day-to-day clinical practice is the cost of the hearing aids. For many of the well-read patients as well who comes to our clinic, whenever we talk to them about hearing aids, when the pricing aspects comes in, they go for a shot. They always correlate hearing to that of vision, and they always compare hearing aids price to be on par to that of what we have it with spectacles and other electronic commodities. So whenever they hear the cost of the hearing aid, that itself would be one factor where people kind of delay it. And the many other factors, which I think Dr. Nambi also clearly discussed and Afrin also clearly discussed. And some of them, they live in denial. So here is where I would want to spend a bit of time. As what we have been used to is about a traditional way of counseling, where the tools that we use to counsel any individual with hearing loss could be audiogram, could be the traditional the ear pictures or the ear videos, and at times we use the speech identification scores. In my opinion, for people who live in denial, where they feel that they do not have sufficient amount of hearing loss which needs to be amplified or which needs an amplification devices. These are the set of people we need to use relatively next level of tools, which could be a basic tool, could be speech in noise test, and I think we must also include speech in noise test in our day-to-day routine for the set of people where they deny that where they have initial challenge of accepting that they have got a hearing loss. And what I have been practicing in my clinical practice is about we need to understand, especially going to decide about decision making for a hearing aid. It's a long term, it's a time taking process. We also need to understand which stage of decision making the patient is. Generally, from the first time he will be in a denial stage, and next time, if you go by motivational interview process, what it says is there are different steps to it. Pre-contemplation stage. This is the stage where patient does not accept that he has got a hearing problem. So in this stage, when you tend to push the patient to go for a hearing aid, he might reject the idea. So at that stage, probably what we would have to further do is we need to equip him, provide him more information about what are the possible consequences of the hearing loss, and give him some kind of a checklist which he could use it in a day-to-day routine and see which part of his day-to-day routine are getting impacted because of his hearing loss. So from there, he would come to a situation where it will be a contemplation stage, where he would think that, okay, now I have a problem. Let me think over what should I do. That's the time when you can talk about amplification. That's the time when you can provide hearing aid trial to him. That's the way we can handle the patients, whoever comes to you who does not accept that the hearing aid trial. And as I said to you, as I mentioned, it is not a one session that we can take off all these things at a single time. It's a time taking process. It might take 2 sessions or 3 sessions to address this particular issue of living in denial. And we also come across majority of the patients where wearing a hearing aid is considered to be a social stigma. And thanks to our technology, and most of the manufacturers have been catching up with the innovations, and now we have got the hearing aids which are invisible, which can cover multiple degree of losses, which was a bit distance dream probably a decade back. And we also have patients who had a very bad experience with the hearing aids earlier, or probably these are the set of some of patients as well are the ones who have a long-standing hearing problem and who could get relatively poor benefit from amplification. So this is the time where the clinician must have to revise or set the expectations very realistic with the set of patients. As we know that not every patient is going to get the same kind of benefit with an amplification. We need to understand the degree of loss, the type of loss, the duration of hearing loss, and accordingly set the expectations realistic. That should be able to help us to get these challenges addressed for the set of patients. And also, what majority of the literature says is, when do people uptake a hearing aid? So if you look into audiogram, which part of an audiogram is going to play a crucial role in uptaking a hearing aid? What it is said in most of the literature is the high frequency thresholds. Whenever the high frequency thresholds are going beyond 35 and 40, this is where patients get more and more motivated or more and more think of going for a hearing aid. So probably when we are looking into an audiogram, could be the one factor we must look into, that is about how exactly is the high frequency thresholds are. This also should help you to decide to help the patient to uptake a hearing aid. And one major factor, in my opinion, I feel that could be incorporated in our day-to-day routine could be the self-assessment of hearing handicap. So what it is being seen when I follow some of our successful clinician, some of my colleagues who works all across the globe, what seems to be a better practice, a good practice being is that also about they go beyond audiogram, speech identification scores, and they focus on more of the self-perception of a hearing loss. So they run the questionnaire something like hearing handicap inventory for adults as well as elderly. So these questionnaires generally now, luckily, all these questionnaires are available in most of the Indian languages, and these are standardized tools that have been available. This is the time when I think all the clinicians must start to use this particular questionnaires. What this questionnaire does is, when somebody who doesn't accept that he has got a hearing problem or who feels that he can wait to take a hearing aids, probably when you run this questionnaire to him, this is all about, whenever you talk about an audiogram, it's all about, it shows that technically what exactly is hearing at each and every frequency. But to correlate it better in his day-to-day routine, what exactly are the challenges that he's facing because of the hearing loss, this questionnaire should motivate him. It's a very simple questionnaire. You can run this in about 15-20 minutes of time. This itself, it will be an eye-opener for the patient. It says that you have got a moderate degree of handicap in your day-to-day routine. You have got a severe degree of hearing handicap in your day-to-day routine. This itself will motivate the patient to do something about it. And in my opinion, these are the reasons why generally people delay to go for an amplification. As a clinician, we need to really understand which stage of decision making he is in. So we cannot speak the same, we cannot counsel every patient in the same language, or we cannot have I would say step 1, step 2, step 3, same for every patient. We need to customize our counseling depending upon the stage of decision making he is in. So initially there could be a decision making, the level to begin with would be, they would be in denial stage, which is like pre-contemplation stage. Next could be the acceptance stage, and next could be in the trial stage. So we need to identify as a clinician which stage they are in, and accordingly provide our inputs to reduce this gap of the delay uptake in hearing aid. Yeah. So, and I think Dr. Nambi has spoken a lot much about what are the probable causes, what are the possible impacts that of the hearing loss, and then I think even Afrin had a real good presentation about what probably could happen as an outcome of an hearing loss. As a clinician, we always feel that hearing loss would only impact our hearing. As Afrin said, it can be a problem with respect to then overall health as well. And in our counseling, what we keep talking about is about hearing loss does not only impact the hearing, it impacts the quality of life. Overall, the quality of life gets impacted in many ways. So can you go to the next slide, please? Yeah. So the quality of life gets impacted over here. People who are not amplified, who are not identified earlier, and then what generally comes as a first impact is the auditory deprivation. I'm sure all of us would have read about it, that the moment you identify hearing loss, and if it goes untreated, the first and foremost evident thing that you could see is change in the audiogram diagnosis. The degree of hearing loss keeps moving up and up depending upon the age and certain other factors of the health. And of late, there have been many studies that keeps talking about the cognitive decline in the individuals with hearing loss. There is one study I would like to quote that is being done by John Hopkins Institute, which clearly says that is people with untreated hearing loss have a higher decline, cognitive decline, compared to the people with hearing loss and who are using a hearing aids. That clearly says that with hearing aid, you can arrest to an extent of cognitive decline. What cognitive decline means to us when we are counseling as a clinician is about decision making, memory. So you can tell them that the ability to decision making or maybe the ability for the memory would get impacted if the hearing loss goes unattended just like this. And it has been very clearly evident that people with hearing loss have quite an impact on the interpersonal and the family relationship. It's been quite evident that people stop talking to them thinking that they don't hear, and the individuals with hearing loss stop interacting with their family and their friends thinking that they just don't follow them, which is leading to isolation, which can make them more and more dependent. Things they used to do automatically, like going out and buying out something from the grocery or crossing the roads, which are like automatic things, that becomes so much and so dependent that they would have to depend on somebody else to even make this automatic things to be done with easily. And for the younger generation, for people who are working and who are still having the hearing loss, what has been majority of the studies says that people with hearing loss, they are poorly productive at work because they do not follow the instructions or they do not follow the hear well. That it's been seen that they've been lesser productive at work, and having a hearing loss which is untreated can create a lot of fatigue, auditory fatigue, which means to say that they need to stress more and more to listen, and hence what happens is generally their anxiety level and the stress level get higher and higher, and at a later point of time the benefit from an amplification also comes down. I mean, you would have seen it day in day out. You would have been seeing it that you would have attended a patient today, they would come back to you after 3 years of time. When you pull out the complete data, it's very evident that on the day one when they visited to you, they would have got a benefit of 80% with the hearing aids. Probably after 2 years of time, this 80% would have come down by 60%. So this is one obvious the impact that the delay in uptaking a hearing aid. And the last and very important thing is about the social withdrawal or isolation, which all of us spoke about. These are the probable impacts that an individual with hearing loss would go through when the hearing loss goes unattended. Yeah.
Really some excellent points. Even I'm still surprised that according to a study that you had quoted earlier, that there's a delay of about 5 to 20 years. Of course, it's a longitudinal study, but delay of 5 to 20 years to go in for a hearing aid. I can only imagine the detrimental effect or the negative effect that it can have on the individual and the family for delaying for so long. And like how you said about how because of the cognitive decline, all the automatic things that would come naturally to the person gets affected. So thank you, sir. Now, before I go on to more about hearing aids and how they help, I have a question to Nambi sir, that is, as a clinician, for clinicians who is working in this field, audiologists, how important are speech audiometry or speech perception tests during audiometry for fitting of hearing aids? Nambi sir, over to you. Nambi sir, we can't hear you.
Achaya, can you hear me?
Yes, sir. Now we can, sir.
Okay, I have trouble in sharing the slide. Can you see the slide?
Yes, sir.
Thank you, Achaya. Already, Mr. Ismail has pointed out the importance of speech perception testing. Often, we do think that it is not customary to do speech perception testing, especially while selecting, fitting, and verifying the hearing aid. We do think that audiogram itself is enough to prescribe a hearing aid. Okay, but the audiogram will only tell about the audibility, but the speech perception is not just device to restore the audibility. It is much more than that. Along with the restoration of audibility, it does restore the speech intelligibility. This restoration of intelligibility happens in so many refining strategy that is done by the hearing aid. Okay, so to decide these refining strategies and to select the appropriate strategies, it is always better to do a speech perception testing, which can help the successful hearing aid fitting. Yes, doing an additional speech perception test takes time, but it's really worth spending time on performing the speech audiometry. As we know that our hearing aid fitting involves multiple steps. Once after the basic audiological assessment, you do determine whether this person should be treated with medication, or it means you should refer to an ENT, or is a candidate for hearing aid. Once you determine that yes, this person is a suitable candidate for hearing aid, then you go ahead with the pre-fitting assessment. Often we do recommend uh, to do this pre-fitting assessment either with the help of a questionnaire. This questionnaire will help you to understand his individual's perceptual problems. Also, it will help you to establish the realistic expectation. So we do the questions can be either standardized questionnaire like COSI or AFAB. Uh, you can use such questionnaire to assess this individual's perceived handicap. So with this, you will be able to decide whether this individual requires hearing aid and what kind of hearing aid, what technology to be given. So we do use one such questionnaire. Either we administer the questionnaire directly. That questionnaire has multiple questions, including the duration when the person has perceive that his hearing loss is present, whether he has used the hearing aid before, was he aware of the hearing aid. It collects the basic data. Then most importantly, it collects the speech perception information. What all the environment in which is supposed to have speech communication, whether market like situation, whether it goes to goes to party, or where a cocktail party situation, whether he has to use a telephone, or it is just a one-to-one communication in the cabin. So it assess what all the environment this individual's speech communication takes place, and how often he is exposed to such communication. So this way we'll get to know about his requirement. uh, what does the hearing aid has to how does the hearing aid supposed to help him with this speech communication ability. And then it is supported by an objective test where we do recommend using an speech perception test. It should be both speech perception in quiet as well as speech perception in noise. So most of the client whom you encounter have where they have to communicate with with their customers or with their colleagues or friends in a noisy situation. So we do recommend perform speech recognition and noise test. So now with many institutions coming up with student research projects and dissertation, there are so many standard tests available to estimate speech recognition and noise. So here we do measure individuals' ability to recognize speech by varying the signal to noise ratio. So we estimate something called a speech recognition threshold in noise, where we estimate what is the minimum signal to noise ratio at which the individual can recognize the speech. So if individual requires a larger signal to noise ratio, then you decide that yes, this person requires some help. So this individual requires a hearing aid which has good technology to improve signal to noise ratio. Also, this test will help in checking whether whatever the individual is claiming, the individual claims that whether I have a problem in speech perception noise, I'm not able to perform well in the market like situation, I'm not able to perform well in the cocktail party kind of situation. So it is like a verification of the subject's perception. If you find there's a contradiction, if the subject says I'm able to do well, but your objective test says no, this person can do well only in the high signal to noise ratio, this tells that yes, this person doesn't have this good means it does not it does not have a self realization about this problem. So you have to tailor make your counseling approach before selecting the hearing aid. Now based on the speech perception test, you select the hearing aid. Like if the person you perform the speech perception test, like he requires a high signal to noise ratio, then you think of a scheme where you have to go for a wireless microphone or directional microphones or digital noise reduction algorithms. Okay, so by using this speech perception test, you select the hearing aid. You select multiple hearing aids which have the required features for this particular person. Okay, though I give emphasis to speech perception noise, the speech perception test need not be limited to speech perception noise only. Speech perception quite also have an importance, especially like clients like high frequency hearing loss, where the audibility or intelligibility of the low frequency sounds are preserved, but the high frequency sounds are not preserved. So if the speech recognition ability for the high frequency sounds are affected, so this itself indicates the need for frequency lowering devices. So so what I'm trying to emphasize here is the speech perception test helps you in the selecting the hearing aid, and this has more importance than the traditional pure audiometry. So once you select the hearing aid, then you fit the hearing aid. So often we fit the hearing aid by programming the hearing aid or adjusting the gain of the hearing aid such a way that the gain given by the hearing aid matches the gain prescribed by the fitting formula. The fitting formulas tell this individual with so much of degree of hearing loss requires so much of gain. So we adjust the hearing aid to match the gain prescribed by the fitting formula. But one thing that we need to understand here is this fitting for most of the fitting formulas try to predict the speech intelligibility based on the audibility. Whether you take NAL NL1 or NAL NL2, often they try to predict the speech intelligibility based on speech audibility. Though they have added some correction factor, but the prediction of speech intelligibility based on audibility is not 100% accurate. Okay, so you program the hearing aid and you verify the gain frequency response by doing a Railier measurement. Okay, so by doing a Railier measurement, you ascertain that the hearing aid is giving the gain prescribed by the fitting formula. So that's where your your responsibility does not end there. You think that okay, the audibility we have provided, the audibility prescribed by the fitting formula we have provided, so this person should be pursuing the speech very well, but that's not the case. Because the predicted speech intelligibility and the actual speech intelligibility may vary from person to person. Okay, so the verification, yes, this particular hearing aid is giving the benefit what it's supposed to give, should be verified using the speech perception test. So the verification of benefit should not be ending with verification of gain frequency response or verification of audibility alone. The verification should be supported by the speech perception as well. if the intended purpose of the hearing aid is to improve the speech recognition of high frequency sounds, so we can use an speech material predominantly with the high frequency sounds to see whether the speech recognition ability with the hearing aid is improving. So that will tell, yes, this particular hearing aid is giving the benefit what it's supposed to give. Then in case if you have given a hearing aid for improving individuals speech recognition ability in noise, so you had selected a wireless microphones or directional microphone, then you place the directional microphone improve the speech recognition ability in noise only when the speech and noise are spatially separated. If they are from a same source, the the directional microphone may fail. So you have to most of the audiological setup nowadays we have at least two speakers, so you can give a noise from one speaker and target speech from another speaker, and then vary the signal to noise ratio and see with the directional microphone individual's ability to perceive the speech recognition noise, or the signal to noise ratio required to perceive the speech, is it improving or not, that can be verified. So this can be an added value to your additional verification of gain frequency response. Okay, so what I'm trying to emphasize here is the speech perception test will help you in selecting the technology as well as verification of the benefit, whether this hearing aid is giving the intended benefit or not. Both can be achieved through the speech perception test. When it comes to speech perception test, often we don't get a clear picture from the patient. Some patients may understand the speech very well, but it's only that they may have some annoyance problem to them. They may not be able to accept the noise. Okay, so they are exposed to a communication in a noise situation. He may not be able to he may not be able to tolerate the noise, because of which because of which also he may say that no, I'm not able to do very well in the noise. There are other clients where they really don't recognize the speech in the presence of noise. So one is acceptance of the noise problem, other one is the recognition of the noise problem. So there are tests available to differentiate these two. One that is called as acceptable noise level test, other one is speech recognition threshold in noise. In acceptable noise level test, what is typically done is a standard passage is presented at the most comfortable level, and we introduce a background noise, and the subject is supposed to say whether he is able to understand the speech well. Here he is not going to repeat the passage, or he is not going to tell what he understood. He is simply going to say whether he is able to pursue the speech without getting tired, or without getting any annoyance to the speech level. So here we are just getting the perception about his speech perception noise problem, since we are not expecting to repeat the speech or the paragraph that is presented. So this does not tell about the recognition ability. It does tells about individual's ability to accept the noise. Other one is speech recognition threshold in noise. Here we expect the individual to repeat the material presented. This SNR 50, SNR 50 is the minimum signal to noise ratio to achieve at least 50% of the speech recognition scores, that we call it as SNR 50. There are standard tests available. So in our clinic, we do use a test developed by Dr. Ajit Kumar. Here, what we present the sentences or a word, you expect the individual to repeat the word presented, or you ask him to write down, and you present the target speech at a various signal to noise ratio. It can be a fixed noise ratio steps like 20 decibel, 15 decibel, 10 decibel, like that. In a fixed step size, you decrease it by fitting a psychometric function, or using a equation like Spearman-Corber equations. You can estimate the minimum signal to noise ratio required to pursue the speech. By combining these two information, we can derive some of the useful information. Like if the individual has a good quick sense score, that is SNR 50, that tells intelligibility. Yes, he has a good speech intelligibility in noise. And if the person has got a good ANL, okay, say he's able to accept even the higher level of noise, then you say that despite having a hearing problem, this person does not have a problem in recognizing the speech in noise, or accepting the speech in accepting the noise while listening to speech. So such individual is not difficult to manage, and you don't have to think too much about this the feature. when I say means we don't have to break our head so much in discussing about the feature. The next one is where his the quick sync scores are too poor. Okay, he requires more signal to noise ratio. Okay, but his ANL is too low. That means he can accept more noise. But these are the individual who overestimate their performance. Okay, they think that they can do very well in the noisy situation, but actually they don't do very well in the noisy situation. In fact, they do poor in the noisy situation. But they feel that they are doing very well. So this becomes difficult for the customers who are dealing with them, or the colleagues or family members to deal with them. So you have to make a tailor-made counseling approach to make him understand his problem, and then go for a feature which can really improve his speech intelligibility in noise. And then other quarter is where both quick sync scores are poor and ANL is also poor. So these individuals have a good perception, means they have a accurate perception about the hearing problem. They have a speech recognition problem in noise, and they do understand that yes, I have a speech recognition problem in noise. So it's easy to counsel this patient, and you can go ahead with the selection of features that can improve his speech perception difficulties in noise. Uh, the last one is this one. Both intelligibility difficulties. The quick sync scores are poor, whereas the quick sync score is good, whereas ANL is very poor. Now these people underestimate their problem. Okay, they can do very well in speech recognition noise, but they think that they are not able to do well. So they may not understand the benefit of the hearing aid. Okay, so you fit a directional microphone, and the directional microphone maybe really improve his speech recognition noise ability, but this individual will not accept that yes, it is improving. Okay, so such an individual requires some demonstration. We may have to demonstrate speech perception, demonstrate speech perception ability using ecologically relevant stimuli, and demonstrate that yes, you are doing well with the hearing aid. Okay, so speech perception test, including the speech recognition ability and the noise acceptance, can help us in selecting the hearing aid, and verifying the benefit of the hearing aid, and counseling the patient about the types of hearing aid and the benefit of the hearing aid. Okay. And when you say counseling, often we as an audiologist, we are very well trained uh, uh, providing informational counseling. We do provide the information about the hearing aid. We do give a detailed information about the capabilities of the hearing aid, in what all the situations that the hearing aid can benefit, how to maintain all those abilities. We do a good job, and we are very well trained. Where we fail is giving an emotional based counseling. If some of the individuals are not willing to accept that they are performing poor, or they are not accepting the benefit of the hearing aid, there could be a psychosocial or the emotional meaning could be there could be psychosocial meaning attached to it. As an audiologist, we should be able to tap those issues and provide an emotional based counseling along with the informational counseling. Thank you, Achya.
Thank you, sir. You have really highlighted about counseling and how to handle a patient if based on SNR and all that. Thank you, sir. So now moving on to hearing aids. I have a question to Chandan sir. This is to tap Chandan sir's almost 20 years of experience in private practice. Next slide, please. Chandan sir, as we had discussed long back, that the hearing aid trial that happens at the clinical setup is just a tip of the iceberg for a successful hearing aid fitting, and for the patient to be happy and listen well with the hearing aid. So do you think, sir, that giving hearing aids on trial, how important is it to give hearing aids on trial? I mean, for the patient to use it for a certain number of days or however, depending on, I know there are practical difficulties, but still, with keeping that all in mind, how important is it, and does it actually make a difference difference for the patient, or for the patient to select, or for you to decide if the patient is doing well with that hearing aid? Over to you, sir.
Thank you, Achaya, and thank you, Isha, for bringing up this topic. Before I move on to any of the slides, I would just like to comment on something to bring up the whole topic. We are talking about a lot of tests that we do day in and day out, and Nambi talked nicely about the process of selecting a hearing aid. I just wanted to bring the focus back on something that all the tests that we do here is with a lot of attention. That is only one task being done at one time. Afrin talked about sharing common resources. This is an important thing that changes the whole scenario. Fitting a hearing aid is very similar to finding an address. An audiogram is like, I have an address, but is that enough to get to that destination? Having a roadmap is much better, and that is what I believe the speech perception test does. But then just having a roadmap makes your route easier, makes your journey easier, but that is not enough still. Something like a Google map has made our life much easier, which takes into account not only the route, but also the driving conditions, the road conditions, also the mode that you are traveling in. Similarly, the speech perception tests tells about the difficulties that the person may have while focusing on that something. And all our speech perception materials that we do are either short sentences, words, or phonemes. Now, do we perceive speech just like that? We talk in connected discourse. We talk with while we are not only listening to a communication, we are doing multiple jobs at a time. I give an example most of the time for those people who say that I can hear very well and I'm understanding everything that you say. They do perform really well in the speech perception tests when we do it in quiet, even in noise sometimes for lesser hearing losses. There I say it's like right now in your phone you are using only one application, but do you run only one application at a time? You see, there are a lot of background applications happening, and after some time you find that your phone has become slow. It does not respond. When you go to a YouTube, it keeps rotating. That's because the phone cannot handle so many applications at a time. Now, it is not only the phone that is handling so many applications. While you are talking, you are also focusing who entered the room, whether the fan is on. You are also thinking about whether should I be ordering a cup of tea or not. So all these things are running in your mind. Now, along with these processing, you also have to process whatever I am talking to you. So it is a parallel processing that goes on. And all this is taking a share from your cognition. So the same cognitive resource that we are talking about. So if you are focusing so much to listen and perform well only to communicate, what happens to those tasks? Now, the topic today was appropriate because hearing is one part of our life. There are many things beyond hearing that makes our life beautiful and easy. So if I focus my whole attention towards understanding what you are speaking, then the rest of my life becomes pale. gets unattended to, and that is what makes your life more difficult. Now let's see what happens when we communicate. Okay, I'm talking really beyond. Can I have the next slide, please? I'm trying to focus beyond the testings and it is for people. I was told that this is for general public, and trying to make sense, connect what we test and why it still does not satisfy most of our clients. Can I have the next slide, please? We when we talk, it is I am a talker and the other person is a listener. That's a complete chain that makes the communication smooth. And when we fit hearing aids, we are very focused about hearing only. We have to be focused about the communication flow, how easily my messages are flowing. And here, what we focus mostly is on the anatomical part, where our hearing devices work. But then, beyond this perception of hearing, believe me, definitely you would agree, I believe, that hearing aids do not do much than just providing the lost stimulus, the lost signals. But beyond that is a physiology that our brain does after taking these inputs. And what we do with those physiological activities is dependent on our psychological well-being. Now, why I say that yes, you need to give the hearing aid for trial, because it's the same procedure of what Nambi suggested, to zero in on certain products. When I have an audiogram, there is a range of hearing aids that can be fitted. After all these verifications, I have few hearing aids. I have narrowed down to few, but then which one is appropriate or which features are needed for this person depends not only on hearing, but on many other extra hearing factors. Like Ismail pointed out, even the cost, the look of the hearing aid, durability of the hearing aid, the maintenance of the hearing aid, all that matters. And unless and until the person actually gets a feel of it, you don't know. On the hearing aid trial, in clinical hearing aid trials, what we see is only the anatomical part. Only when we have usage history, the physiological things ease up. That is where we see that the tolerance to noise, that uncomfortable levels are really reducing. This is something that I definitely do in all fittings, is measure the uncomfortable levels for this person. Now, what I have been seeing is with usage, we see that the uncomfortable levels slowly drop down. That is, their tolerance increases. That is why where I feel your auditory system is relaxing out, and that is relaxing because earlier this person had to focus a lot to understand. And definitely you need to know that you need to do a lot of auditory training for this person to make use of this extra hearing that is being given. Now, you cannot do all that usage history, auditory training. You cannot do it in clinic in one session or two sessions in short duration. You need to try this out in real life over a period of time. And unless you have done it, you don't know. One of the most important things is how long will the battery last? How do you answer that? How long the battery lasts? Unless and until this person's hearing is used, and this all my tests are just predictions. But then unless and until this person really tests this out, you don't get that emotional connect, and your credibility is just based on certain literature data. When you give those literature data that it is expected to do such and such thing in such situations, and this person really finds that it helped, that is when your credibility goes higher and acceptance of hearing aids become higher. I say it like I am drawing. When I fit a hearing aid, it's like I am drawing a portrait of your mother. Now, I have not seen your mother. So I have seen my mother. It's my perception that you would probably like this hearing, and that is what I have. That is how I have programmed that hearing. It is you who have to try this out. You have to see it, and then you have to say, so probably she looked a little fairer. Probably her hair was somewhat different, and depending on that, I change the sketch. And finally, my portrait should look like your mother. And that is why this communication, this feedback needs to be done. A very common example that I keep giving is, if I am to cook a dish for you, I would put the namak, haldi, sugar based on my taste. And it is you who have to give me the feedback that how did you like it? And all this cannot be done based on, okay, Malayalis like it more spicy, so put lot more spice, or Bengalis like it more sweet, so put a lot of sugar. That is an average data. I may not like. I generally do not like sweet in my dishes. So, it is this individual feedback, individual experience that makes the fitting, the counseling more customized. And I personally believe, we owe them this customized service, and that finally improves on the acceptance of hearing aids. I think I have answered these questions. Just one, the next slide, please. That will summarize why I do it. Can I have this next slide? Yeah. So this is, I have already talked about it, that communication has a purpose and content. So communication is our goal, and speech is just a tool. Okay, remember, we are focusing on communication, and speech is one of the tools. How we use speech in communicating is what is important. Our goal is understanding, and speech occurs in real time, not in sound treated rooms, not in nicely paced thing. The spacing of words, or rate of words are important things. And we use shared resources. So speech perception is a gestalt perception, overall perception. The noise, if I keep only the speech and no noise behind, it will not sound normal. I need to explain this to the patients. So it is like an overall perception that needs to be enhanced. The overall communication needs to be enhanced, made easy for this person. And it's just not speech being made more clearer. Just making speech clearer is not the purpose. Making the communication easier is the purpose. I hope I have answered the question. Achaya?
Yes, sir. You easily weaved such a complex topic so easily, sir. Thank you so much. As you said, communication, or understanding the communication, is important, not just speech. Thank you, sir. Now I move on to the next question. This question is to Mr. Avinash. Avinash, what do you think are the factors or features in a hearing aid that helps the hearing aid wearer the most? I mean, what should an audiologist always look out for, or not miss any of the features? Which features while programming a hearing aid? Over to you, Avinash.
Hi, Achia. Hi, everyone. Good evening, and thanks for the question. I think if we can go to the next slide. All right. So when I looked at this question, I was actually I was smiling, thinking, there are so many things which we look at in fitting hearing instruments, and I said, okay, let's pen down a few of the important ones, which I think rightly, like Chandan was speaking, and even Nambi spoke earlier, that which at least give you the highest amount of audibility, and also strategies to improve signal to noise ratio. So just looking, I don't want to take too much time explaining every single thing in great detail, but what I will touch upon is the guiding principles of a hearing instrument fitting. Okay. Now, the three things I focus on generally, and it's been something which a lot of people have helped me over the years, is audibility. That is, the goal of amplification is primarily to give audibility to our patients. Following that, the next important thing is, once they hear, we look at the intelligibility and also comfort. Intelligibility, because is the person able to understand, and as we know that the hearing instrument amplifies the sound, beyond which most of it is actually left to the brain and the high auditory centers to perceive the sound and to make sense of what is being actually heard. The most important thing after that is comfort, whether the user is going to be very comfortable wearing the instrument, is he comfortable with the style, is he comfortable with the level of audibility, is he comfortable with the usability, and these are parameters which I think all of us should consider while fitting an instrument. So generically, these are the three broad categories we can look at. Furthermore, if we are looking at essential features, looking at the kind of noise we face in India, whether it's cities, metros, tier 1, tier 2, tier 3 cities, workplaces, etc. Noise reduction is something which is very important. How much noise reduction, that's a separate topic for discussion, because too much noise reduction again isn't really good to for any patient to use in any environment for that matter. Directional microphones are important because they actually help in focusing and localizing the direction of the source of sound. They also help importantly in improving the signal to noise ratio. And as the key of Nambi's presentation, signal to noise ratio strategies are extremely important when fitting a hearing instrument, because that actually helps significantly in intelligibility and also in comfort, right? Rechargeable batteries. Nowadays, a lot of instruments have what we call Bluetooth capability. Changing batteries might become an expensive affair. So most manufacturers have shifted to lithium-ion batteries, which is now the gold standard in the industry. There was a brief period when some people used silver zinc batteries, which are actually water soluble, but unfortunately do not have the reliability of lithium-ion batteries. So rechargeable batteries are things which you should consider. Again, if it's it depends on the person's lifestyle, and if they're going to forget to charge their hearing aids, then rechargeable batteries are a bad idea. Ingress protection rating. So if you can look this up, ingress protection rating is how dust and water resistant is the instrument. We live in a quite dusty and environment in our workplaces when traveling, and also the occasional rainfall, the sweat, moisture, humidity. All these are factors which I would consider very seriously when recommending an instrument. So just to tell you that 6.8 currently is the highest in the industry. 6 stands for completely dust protected, and also 8 is basically it's suitable for submersion underwater for 1 meter up to 1 hour under standard test conditions. But most importantly for our patients, it means that they can use their instruments, whether they sweat, etc. The instrument won't get damaged that easily, provided they use a dehumidifier and look after their instruments. Yeah. So telecoils has been a subject of, most manufacturers still use telecoils, but unfortunately in India, we don't really have telecoil-enabled public address systems, movie theaters, and other places. So while there's a small segment of patients who have been using telecoils for the last 10 years with their hearing aids, you need to look at whether that patient really needs a telecoil or doesn't need a telecoil. Coming to connectivity. Now, this is a very hot topic of discussion in all hearing manufacturers forums, because there are two it's a very clear differentiation now between universal, which means that Phonak, Unitron are two brands which we use, connect directly to all Bluetooth devices, whether it is a phone, whether it's a laptop, whether it's a MacBook Pro, whether it's an iPhone, an iPad, etc. And it seamlessly connects for your phone calls and for media streaming. Also, there are made for iPhone devices which work extremely well with Apple. And then there's the Android streaming protocol, which is compatible on a very few devices which use the latest Android operating system, I think 11 and above. That's a separate technology. But if you're looking at what are the technologies I would, any one of us would actually consider what is important in a good hearing instrument fitting, these are parameters which, are really good to look at, because at the end of the day, we want to integrate our patients into a normal hearing world. A normal hearing world includes the complex ecosystem of Bluetooth connectivity and wireless devices. And just food for thought, how many Bluetooth devices do each of us connect to? I myself use about 10 or 12 devices. Yeah, but that's of course because I connect to my hearing instruments as well. But there are Bluetooth speakers, there are my phones, and a couple of Bluetooth headsets as well. So if we as professionals, use say about 8 to 10 devices or even 4 to 10 devices, why not our patients as well? So that's food for thought there. I think if you can go to the next slide. Yeah, remote controls. I think the take here is that do they really need a remote control? If they use the remote control, it means that they are constantly fidgeting and adjusting their instruments, which I think is not really needed. However, if there are a certain section of patients do use remote controls, they are used to using them for the past X number of years. They have migrated from analog instruments to trimmer controls and now are on digital, and they're used to adjusting their volumes, etc. So maybe for a select group of patients. But otherwise, for a first-time user, I would strongly suggest that we avoid adjusting the volume, etc. Because when we're sticking to a prescriptive gain, and we're expecting the brain is actually doing most of the work, right? Adjusting of the gain, etc., might not be a really good idea. Remote assistance, synchronous versus asynchronous. So synchronous means that you have a cloud in between. Sorry, there's no cloud in between. It's a real-time, video call where you speak to your patient, you sort out his issues, you adjust his instruments, and you close the session, right? So while that needs very strong internet bandwidth of at least about 5 Mbps upload and download, the asynchronous version is also available in some instruments, wherein you have a cloud where the person kind of you can upload the settings based on the patient's complaints and requirements. He can choose to install those settings, or he can choose to revert back to the old settings. So it's something which I would consider is important, but it's not a sole deciding factor. It actually depends on the age of the patient and how good the fitting actually goes. If there's connectivity separating the patient from the clinic, it's difficult for him to step out, it might be a good idea to look at remote assistance. Right? And direct audio inputs. So again, considering hearing instruments and also implants, if you're looking at streaming, there are if you want to connect to a TV source or use an accessory from a different company, right? A direct audio input might be a good idea. However, it's lower down on the list, but it's something to be considered. And the last two are variable or manual programming. I covered this point in part a little while earlier with the remote control. Constantly switch, or should we look for an automatic system, right? Which is what we call a little easier to which looks at the environment, which changes directionality, noise reduction, speech enhancement, and other features to cope with the background sound, right? I feel that's a much better option than giving a complex set of programs to the patient, which might actually confuse and might not provide stability of sound if the patient forgot to switch programs. So it's always good to take an instrument which has automatic what we call program managing, where they can actually switch depending on the background sound. And the classifiers now have improved significantly to detect speech, speech and noise, comfort and noise when there is no speech, just quiet environments with little bit of speech, and quiet environments with no speech. Yeah. And the last thing is binaural synchronization. It's important now that a modern digital instrument talks to each other, whether the person is increasing volume or whether he's changing program, or when he is in a noisy situation and the hearing instruments need to know where the noise is coming from. Nabi was mentioning earlier that if the noise and speech is coming from the same source, it becomes very challenging, and I completely agree with that. And that's another topic which will come up later about wireless accessories to bridge the signal to noise, the gap in the signal to noise ratio. So binaural synchronization to help in better signal to noise ratio and improving performance and noise is something which also needs to be considered. So on that note, this is my small take on the instrument, the technology. Achay?
Thank you, Avinash. That was really well put and crisply as well. Thank you for that. Now I'll quickly go back to Chandan sir. Next slide, please. Chandan sir, we discussed, even Nambi sir and Ismail sir both discussed about, in part about verification. Now, I want to ask you, sir, how do you ensure that the patient is hearing what you want him or her to hear? That is, as you said, partly you said earlier that about understanding, or maybe the patient is not actually hearing what you want to hear. How do we verify that, sir? How do you, sir?
Yeah, thank you. Thank you, Ajay. How do you decide what this person wants to eat when he comes to a restaurant? You ask him, right? First, my session for a hearing aid starts with a very good interview about what are the situations that he feels problem in, or does he feel problem in at all. And while I am talking about this, I also have a knowledge about what kind of hearing loss he may have, either through a communication or through previous audiograms. Most of the time they have a previous audiogram. So from there, I have an idea about what would be their hearing audibility status. So I first of all focus a lot on why they have come here and what are the situations that they feel they have a problem. After that, I collect my audiological data, and then I also give them some pointers as, don't you think you also face a problem in such situations, or how do you feel communication is in such situation? Like that day, a person came with unilateral hearing loss. The main problem, and through the interview, he kept saying, I hear only through my one ear. That's all. I don't hear through this ear. So what does it mean to you? It just feels odd that I don't hear through one ear. That is all that he kept saying. After I thought it was an unilateral hearing, but this ear has got some hearing. Then I found that the one ear, the left ear, was completely dead. And then I asked him, don't you think that when you travel in a car, you have to sit on one side only? If you sit in a rickshaw, the person who is talking to you from this side, you have to turn every time. He said, yeah, that's what happens. Yeah, that is a difficult. I have to turn, but if I turn like this, I can manage. This is a very important statement. I can manage. So then my question was, how difficult or how nice do you feel to manage every time? So it is a question about how much of difficulty in all situations this person has. So basic thing is, I have to know and ask that what are the situations and what are the factors that are most important in this person's life. Now, how I do it is it's mostly based on the COSI, but I do not follow. I do not use the COSI. I started doing it, but then I felt these questions. Every time I give them the questions, I have to translate and put them, make them understand. So instead of it, I have incorporated that in my interview, and I make a note of things that they find it difficult. So I make some number of situations, and then after this I tell them, out of 10, tell me how do you score yourself, your difficulties in these situations. So these are the difficulties that you said are there, and this is what how you score it. Now the next question is, how do you verify the usefulness of this aid after this trial phase? I say during this trial phases, now that you have used this hearing aids, my solution, I don't say a hearing aid, I say after you have used my solution, because my solution is not restricted to a hearing aid alone. I do a lot of counseling to the family members about what to expect, the user also what to expect and what not to expect from a hearing aid. A hearing aid is not a genie. So, and second thing is the family members, I train them a lot on clear speech. A very old concept, but a very effective one still, because they say that when they are talking to me, when this person understands everything that you speak. I said, let's talk. You talk to him while I am there, and I lead the conversation for some time, and then the other person, the family member, talks. And they said, here they understand even when I am talking. That is, the family member is talking, but ghar pe nahi samajhte. At home they don't understand. Why? Because I say, do you speak at home like this, how you are speaking? They don't speak. Most of them, what happens is, when I speak to them in a clear speech, when I speak to them in a well-paced, well clear way, they also start speaking at a lower rate, clearer way, clearer voice. And that is what makes a difference. Now, most of you would have said that I don't follow the conversation between both of you, but I can follow when you are talking to me. Okay, why is that? Have you thought of it? Because when I speak to a hearing impaired person, or anyone for that matter, my rate of delivery of speech is very well dependent on that person's feedback. He keeps nodding, and if I don't get those nods, I go slower, and that is what happens. Like when I speak to a normal hearing family member, I would speak faster, I would speak maybe not so clear, because he is still responding back to me. But when I speak to this person, I would, my rate of speech, my pronunciations will automatically change, and I demonstrate this difference to the family members, and that is when they also start using the clear speech directions. Now, so that is why I say I have provided you a solution, not just a hearing aid. Now, then I ask them after the trial, how do you rate on these points today? Okay, and when I do that, I don't show them the last day's scorings. This is actually a scoring or a report card for me, how well I have given the solution. And then both are compared. And then we decide that, okay, these solutions have been already answered, but these solutions need to be worked on still. Now that can be, then I give them a timeline of how long it may take. But then I cannot, unfortunately, cannot extend the trial for all that. But then definitely a trial gives the confidence and gives me the confidence that I have given them a useful solution. So my job as a hearing service provider is giving them a better communication and making them hear what they are lacking in, making their communication better in only the situations that they find it important. Taking point from what Avinash was talking, a remote control. This person does not need a remote control. So why should I give him a feature of remote control? This person does not hear. Can hear very well with just a pair of hearing aids, the TV. He can hear very well. So why do I need to give him a wireless TV? So I need to very well focus on the solutions and then give the solutions. Focus on the needs and then need-based solution. Because it's coming, these features are there. If I put it on and give all the access to the patient, it makes the person's life more difficult rather than easier. So that is how I would forth my views on this slide. I am not sure whether it was on. Okay, that is not needed as such. I have already talked and explained all that really. Just that to test, we have to challenge the system. We cannot just rely on in-quiet speech perception. We have to introduce noise, as rightly said, speech in noise, but also parallel processing. Speech in noise is not only challenge. Speech in noise while doing many more things is the real life situation. Thank you, Achaya. I will take up questions if there are further ones.
Thank you, sir. We'll take the question and answers slightly later, sir. Now, I think for a lot of years in my practice, I've always been referring or fitting patients with hearing aids and in adults and not concentrating much on cochlear implants. But of late, there's been a lot of discussion that cochlear implants can be and should be given to adult patients with adults who have hearing loss. So now I pose this question to Dr. Aninda, that how has the paradigm shifted for referring patients for cochlear implant in adults, and also, and what is the current status of awareness of CI in adults in India? Over to you, Dr. Aninda.
Good evening, and thank you for the question. I will talk about can I have the control on the slide? Yeah. So the first thing I'll discuss is in two parts. One is your paradigm shift, and it's very interesting to see what has happened in the last 35-40 years, because right from where multi-channel cochlear implants was established and approved by FDA, there has been a drastic change in the entire candidacy criteria itself. But unfortunately, the candidacy criteria has moved, but you'll go seeing ahead that we have not moved along with it, and that's an important point. So it all started from where we were talking about only profound hearing losses had to be doing you have to do cochlear implants in adults. I don't have the control. Right, thank you. Yeah, so now this slide, if you can see out here, there is an entire shift of your candidacy in cochlear implants. Especially I would like to highlight the cochlear implants in adults. Like right from 85, if you see, FDA had approved only profound losses, and then in the late 90s and 2000 is when we moved to a little better, probably with more clinical trials, into the severe to profound category. But yet we were not so cognizant about a very important aspect that has been over and over time discussed today, is about speech perception, and that importance came in the last few years. If you see, the entire candidacy again changed out here, where you need to do, apart from your audibility test, like an aided audiogram that most of us probably is doing, or we do it at a much later stage when it really clicks that you have to do a cochlear implant, but we forget
or we don't really have that tool of recorded speech perception test in the clinical population, in the clinical centers. But we miss to see that even if the patients don't reach that 50% mark, or let's say 50, 55 or 60% mark, they are still in need of a cochlear implant, and that is what your candidacy talks about. Unfortunately, these are not tested, and these are not tested, and there's a huge population of around 80% adults don't even know about cochlear implants. I'll move to the next slide here. Yeah. And now with these changes, if you see in the last 2 3 years, or let's say 5 years, there has been a lot of off-label work happening. But now even you see there is a lot of candidacy changes giving importance to residual hearing, let's say below 1000 hertz or 750 hertz, where they are candidates, or where there are audiograms of mild to moderate, and the rest of the frequencies, they slope onto the severe to profound side. This is a typical audiogram that sometimes over and over we keep using hearing aids, changing hearing aids. Even the best optimal fit hearing aids sometimes doesn't give that much of good gains or good speech perception. And again, we miss to test that, and that's why we miss this entire adults who is actually a candidate of cochlear implant. And the duration of deafness keeps increasing. We always talk about lesser the better, but we don't look into the current candidacy, and this is where we need to focus on, because that's where the candidacy has changed in recent times. We don't have time today to talk about single-sided deafness, but cochlear implants today is also actually approved to be done in single-sided deafness, and there have been off-label work done in even pediatric population on the single-sided deafness with cochlear implantation, and that's a separate topic altogether. But candidacy has moved towards this part entirely. Uh, as a role of audiologist, it's I keep telling all students and discuss with professionals that we play a very important role right from the beginnings, because we are the one, the audiologist is the one who's actually assessing and trying to find out whether you can do something more, or you can do something which is beyond the regular practice of probably hearing aid fitting and habilitation. But is there a cochlear implant possibility? Because as an audiologist, we need to understand that there are better electrodes which have been made. Surgical techniques have become better. Electrodes have become thinner, which allows you, pure round window insertions. It helps to entirely, you can see this green area marked here. It helps to preserve that residual and structural hearing by EAS systems, and even not using EAS, you can still preserve it with better electrodes. Today in the OR, the operating room, an audiologist can do an active insertion monitoring. While the surgeon is inserting every millimeter, you can actively monitor and actually save those structures and preserve those hearing, because later on you can do wonders with this kind of an audiogram even in cochlear implants. And that's where your role of an audiologist comes. And I think we should keep updating ourselves in that way, so that we are able to give the best to the patients, and not shy away from talking about cochlear implants to an adult population. So this is the entire paradigm shift that has happened in cochlear implantation, and I think we need to be updated about this aspect of it, and always set your realistic expectations with them. Now, your second question was about the adult cochlear implantations awareness, and it's an eye opener, I would say. So we did this research project along with we had offered it to one of the students, where we developed the tool to a questionnaire, and then we took it at a multi-centric level across complete India, across 7 states, that we tried to find out what exactly, how much professionals as well as the actual patient knows about cochlear implantation. Can you go to the next slide? I'm not able to control. Yeah, thanks. So this was done with student Divyang and Professor Madhuri Gore from Dr. Chandrasekhar Institute, Advanced Bionics, and there were many other centers involved to get this data out. We know that all over the world, the penetration of cochlear implant has been very low. WHS has mentioned about 460 odd million population, out of which more than 90% are actually adults cochlear hearing impaired. And out of that, a huge bunch is actually where they are actually candidates for cochlear implant, but they don't even know about it. We always think cost may be the factor, but it may not be. So we were trying to understand whether it's only financial aspect, or was it something else at the professional level, at a personal level. Why aren't people going to the stage of candidacy or assessment for a candidacy, or even if one is going there, they're not seeking one, the patients are not seeking one. So we looked into data of more than 350, around 387. But again, I think I lost control. Yeah. So across 7 states, and they were segregated as per the RPWD Act, benchmark disability to understand um, uh, which categories do they fall on. And it was astonishing to see that 86% knew about hearing aids, but hardly 17% knew about the cochlear implantation, and 83% had never actually heard about CI, although there was a huge bunch of them who were actually candidates for cochlear implant. uh, Hardly, and these are centers where I was saying people are going to the centers and we try to get some data out of it. uh, I think that's where the awareness broke down. Most of these adult patients didn't know about cochlear implant, or they are suitable for a cochlear implant itself. They were not aware of the exact team who is actually involved in a cochlear implant cancer. As an audiologist is involved as a cochlear implant, uh, a professional who provides cochlear implant, it was unknown. And hardly 6% knew about the benefits of cochlear implants, although they were candidates. So these were pretty alarming results out there. We talk about cost, but actually less than 10% really answered about cost being an issue. 88% actually they said that cost was not an issue, because they were not aware of it, because we later counseled them, and that's where the entire changes happened. One important feedback which we got from these more than 300 patients was that they got information about cochlear implant via media, via Google, via everything else, but not the audiologist professionals. And me being an audiologist, I think I fall in the fraternity, and that's where we need to change the environment altogether. We talk about hearing well-being in adults, and geriatrics were a major part of it. We talk about that Western world is doing it, but India doesn't do it, or developing countries don't do it, but they fall under this category, and that's a pretty big number there. uh, the next slide, please. Yeah. So we talk we 57% actually were they said they are poor, they do not have good benefit with hearing aids. And of course they were into this criteria, this candidacy of cochlear implantation. So that's 57 out of 387. That's a huge number of adults who need cochlear implants. And this is a qualitative 57%. We've talked about speech perception test. Unfortunately, it's difficult to even get recorded speech perception test in sentence tests also in the clinical world. If we start doing that, this 57% is going to definitely shoot up, because that's when you quantitatively also see where they are actually falling. These findings were, of course, similar to other developed countries. And remember, these developed countries have a lot of funding system, but yet awareness was down. And that's where we started comparing that there is some issues which I think it's our hindrance to talk about cochlear implants openly, and go beyond the thought process that there is something that you could go. Maybe it's a shortfall from our thinking, or something is going wrong in between. But a patient needs to reach that candidacy stage, the assessment stage, and that's how things will get better, because you ultimately have to improve the quality of life. So that's where I think a role of SLP will really come in. 20 years ago, we see so many schemes happening for children. 20 years ago, it wasn't. Why? uh, Over the years, evidences took place, and we saw that children were benefiting so much. So that's where, when we start to advocate more of adult CI, you will start to see evidences. These evidences then go on to the panels, and that's where maybe after 20 years you will start see that there would be schemes for even adults, because they also want to enjoy that quality of life. I'm talking about even postlingual or prelingual, both adults. So that's where I would put forward that where awareness actually stands at, and we need to have to buckle up our seats there, considering the candidacy has also changed over time. Yeah, that was my take on that.
Thank you, Aninda. I think a lot of discussion has to be done on this, and because of lack of time, I don't think it'll be possible now, but maybe probably in future we can take it up and then see how it goes. As you say, create awareness about CI in adults as well, or at least talk to patients who are candidates for CI about that, and then see where it goes. Thank you, Aninda.
Thank you.
I'll just take one, I'll just ask one last question. Next slide. To Ismail sir. Next slide, please. Next. 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 Yes. While I was working in Bangalore, this was a common issue that I used to face. That is, a lot of misconception or irrational fears, as Nambi sir mentioned earlier. That is why reading the literature that is readily available on Google or any other website. This always used to, I mean, the first reaction would be from an audiologist perspective, maybe irritation that first we'll have to erase everything that they have read and then give them the new information. But I think on this, Ismail sir will be better equipped to answer. So I ask this question to Ismail sir, that how do you deal with Dr. Google's patients? Ismail sir, over to you.
Yeah, thank you so much, Chair. So can you move to the next slide? Yeah, first thing first is that we cannot stop this, and then given the penetration of internet that we have witnessed in the last decade, I think every individual, irrespective of the socioeconomic status, irrespective of the literacy, I mean, they are well equipped with information. It is freely available. You can access to any kind of information all across the globe. That's going to only get better in the days to come. Hence, it's natural to see more patients who have been Googled up everything. I mean, it could be about any part of the things that we do. I mean, often I do get to see patients who have misconception about tinnitus. They read something about it and then they interpret in a very different manner. As a clinician, the first thing first, what I would suggest is don't discourage such kind of patients. I mean, when they come reading, if imagine if they have come to you for a consultation and they would have had some doubts and they would have read up something about it and they come to you saying that, is this referring to this kind of a problem? The first thing is I appreciate them. I appreciate them that I'm glad that you have read something about it. I'm glad that you made some attempts to read more about it. And this only instill some kind of confidence as a clinician. And from a patient perspective, he feels that his challenges or his misinformation is getting resolved, and he's at a place where all his queries or all his concerns are getting resolved too. That's what builds the trust in the clinician. And it is a very crucial factor as a clinician to win over the trust of the patient. The second thing is, as a clinician, I always make it as a practice that in case if they wish to, I always direct them for some good information. If there are some websites where you would know that there would be some kind of information which could be very authentic, I rather at the end of the session, I rather hand over some kind of website information to them or some reading information to them, which gives them complete overview about the challenges that the challenges that they would have or the information they would want to know about. So here, what I would like to do is I would like to educate them by giving the right information. Third thing is before this discussion, you'd also need to ask the patient regarding what made them to read about it and what exactly are the reasons why they are worried about it. Understand the baseline underlying question for which they would want to look into, and understand if they got some kind of an anxiety over the issue, and address them. As a clinician, you would know it better, and given the different wide variety of set of patients that you would attend to, you would be able to address them better. So understand the underlying question and address them. And then the last thing is probably towards the end of this discussion, I would also explain them what are the probable limitations about the information that is available over the internet. This in a very subtle way, you would want to know them that not everything that is available on the internet is correct. and hence they need not to worry about everything they read about it. Hence direct them to the right information guides, which could help them to be less stressed about the information. Yeah, that's it.
Thank you, sir. I mean, you have, for the lack of time as well, you've explained it pretty easily for us to understand, and I think put it into practice as well. Here in the Q&A section, I think there were a few questions, and I think it has been answered publicly already. But if there are any questions, we can take it now, or we'll call for closing comments. Or if any of the panelists want to add on to anything, and then we would conclude the panel discussion. Meenakshi ma'am, Krishna sir, I think.
Just one quick comment before before we shut down is that all outcomes are good outcomes until we measure them. So I would strongly suggest that all of us endeavor to measure our patients' outcomes before calling it good, because what can be measured is actually what the patient takes back home and actually gives us that professional edge over everyone else. Yeah. So thank you very much, everyone, and it's been a fantastic presentation by all of us. Thank you.
Thank you, Avinash.
One more comment from my side.
Yes, sir.
Just like I just want to add on to what Mr. Avinash said. Yes, we have to measure the outcome, but we have to treat individuals' hearing loss as like a fingerprint. The hearing loss of one person may not be same as hearing loss of other person. Hence, the selection, fitting, even the counseling approach has to be tailor made for that particular client. And one more thing to add on to Chandan sir has beautifully answered to the question in the chat box. Sir has answered the second part. The first part, I want to add a bit. Like the brain is has a unique role, but now when the person has a hearing impairment, the input that is given to the brain is not intact. It has been already distorted. Moreover, the environmental factors like noise and reverberation can further distort it. So you are giving the distorted input to the brain has to do the repair job. Okay, so now if you give a hearing aid without any special feature, the brain has to do more job. But if you have some features like wireless microphones or directional microphone, that way you are enhancing the input that is given to the brain, thereby you are reducing the brain's job of repairing the distorted input.
Yes, sir. Agreed, sir, that the load on the brain can be reduced if the features are more in the hearing aids. True, sir. Thank you, sir.
And one last comment is, like you rightly said, Nambi, the features developed for hearing aids are developed by human brains, right? Human brains develop those features, so that's why the technology is expensive. But I think we should be conscious of that and look at cost factors before recommending them. What exactly is recommended to our patients? Yeah.
I just want to summarize one thing. Out of all this, ultimately we are looking into the giving the adult, we're talking about hearing well-being, a very smooth interpersonal relationship, because communication breakdown happens the most. Thanks to my guru, like Professor Rangasai sir, who has actually taught me about third-party disability. Doing whatever we do as a role of audiologist, we are trying to do everything clinically correct, and we're trying to counsel the patient at the end. But ultimately, we're trying to, for that adult who is actually in their home environment, personal, professional life, and there's so much of impact on the third-party disabilities that happens on them, on the family members, spouses, that has been reduced by, that's what we are trying to do, and that's your main goal, that the entire, whatever we talk about, comfort of listening or ease of listening or cognitive capabilities becoming better after things, but that is your ultimate goal, that we're giving a better quality of life to them.
True. It's reducing the burden on everyone. True. Agreed.
Thank you so much for this wonderful session, and thank you for making it more like patient centric and patient, to build awareness to the general public. The questions were really focused on that. Thank you so much. I would like to thank all the panelists, and I would now request Naika sir to give some closing remarks. Naika sir, I think Naika sir, Krishna sir.
Yeah, coming.
Second.
Uh, Thank you for all the panelists for making this event a successful one. You should, yeah, Naka sir is here.
I think he must be joining,
Okay.
Yeah, he's there. He's there, sir. Yeah, connecting.
Please go ahead. Anyway, thanks from my side. From all of you have been really informative, giving information on the hearing loss, especially how it has to be addressed with the developments that are happening. With Google, Dr. Google, how
Yeah,
we can handle. Very
especially,
good input. And I'm sure the audience would have got the benefit of it.
yeah.
Like sir, for you.
Naika sir.
Thank you all. Let me just tell one thing. It was music to my ears even after listening to audiology topics for the last 35 years. I wanted to just share one case story. Um, I had one patient who came, one fine day, landed in my clinic, and then I was taking cases and asked him, "How do you know? Why did you come? What is your issue?" Then he said, "I have difficulty." Then the next question was difficulty in hearing. Since how long? He said, "Since 1 month." How did you come to know about it? He said, I had been to my friend's house. This was early days where the only landlines were there. So he had been to his friend's house, and his friend was talking using the earpiece. He was shifting from one ear to the other ear and talking for a while. And this fellow, for the first time, realized that people can hear from both the ears. And he had one unilateral hearing loss. And when he realized that his friend is using both the ears, he came to consult me. Hello, everyone. Today's session is really elaborated on how important is to have a sound knowledge of the prerequisites for prescription of hearing solutions and hearing aid fitting, our cochlear implant rehabilitation program. The multiple factors which are generally overlooked can be of utmost importance for a memorable experience or the patient satisfaction. I'm happy to know that there is a strong take-home message from the eminent audiologist in the panel. I thank all the experts in the panel, Mr. Avinash, Dr. Arivudanambi, Dr. Aninda Banik, Mr. Muhammad Ismail, Mr. Chandan Shah, Ms. Apri, for their excellent and wonderful discussion. Finally, let me thank Mr. Achaya for his lovely questions and lively discussion. Thank you all, and goodbye for now.
Thank you, sir. So please don't forget, tomorrow also we have a very, very practical, very exciting topic. Please inform all your patients. We are going to be talking about the benefits, concessions, policies for persons with disability. This is a topic most of our patients come back to us asking us about this. So our request is that, genuine request is that please inform as many people as you can about this topic, so that everybody can be, everybody can benefit from this session. Thank you very much and good night. Thank you all the panelists, Dr. Krishna, Naika sir,